Welcome to today's session on sodium disorders. This is part of our electrolyte series in PHRD 515, renal disorders. I am Dr. Jeffrey Gonzalez. This is a pre-recorded lecture that will complement the in-class lectures on fluid and electrolytes. Sodium disorders are among the most common electrolyte abnormalities you'll encounter, and they can have serious consequences if not managed properly. Today, we'll break down the pathophysiology, clinical presentation, and monitoring strategies for both hyponatremia and hypernatremia. Here are the learning objectives that you should familiarize yourself for this session and for the purposes of the exam and quizzes. Please review the chapter on sodium and water homeostasis in DePiro's Pharmacotherapy, 12th edition. It provides excellent clinical context and reinforces what we cover today. Now let's start with the basics, normal sodium values. Sodium normally ranges from 136 to 145 milliequivalents per liter. Knowing these reference ranges is critical for interpreting lab results. For example, if you see a sodium value of 128, you should immediately think of hyponatremia and start assessing the patient's volume status. And conversely, if you see a sodium value of 155, you should immediately think of hypernatremia and the clinical consequences of this disorder. Why is sodium so important? Let's look where it's found in the body. As you can see on this diagram, sodium is a primary extracellular cation in both the interstitial fluid and the intravascular space. You can see it's relatively high compared to any other cation or anion in the extracellular fluid. Clinically, we can measure the patient's sodium level with the blood taken from the intravascular compartment. As you learned in the fluid and water balance lecture, sodium is the main determinant of plasma osmolality and total body water. The formula for osmolality includes sodium, glucose, and BUN, and is listed here, which you should memorize. Sodium disorders are often linked to water balance, not just sodium levels. Because of tonicity, sodium regulates water distribution between compartments. Always consider volume status when evaluating sodium disorders. As I mentioned, most of the sodium in our body is found in the extracellular fluid. The normal plasma serum sodium is listed there. Disorders of sodium lead to volume disorders, and conversely, a volume disorder can drive a sodium disorder. Usually, the body is quick to correct either the sodium or water imbalance through various mechanisms as previously described. However, these mechanisms can be overcome or malfunction, which leads to sodium disorder. When it comes to sodium disorders, patients are usually asymptomatic unless it's severe. This means that we usually first identify the sodium disorder by the patient's laboratory value and not their presenting symptoms. If symptoms do occur, the main organ affected is the brain. If the change in serum sodium occurs acutely within 48 hours, the brain is unable to equilibrate and symptoms are more likely to develop. In sodium disorders, patients may present with nausea, a general feeling of unwell, headache, lethargy, disorientation, confusion, and possibly seizures. Hyponatremia is any serum sodium less than 135 milliequivalents per liter. It can be divided into mild, moderate, and severe depending on the level. You are not expected to memorize these severity cutoffs. Instead, it's important to know that the lower the serum sodium, the more likely the person is to have neurologic symptoms of the disorder. Most cases of hyponatremia are in the mild category and are not likely to have neurologic symptoms. The presence of any neurologic symptom indicates the need to correct the sodium disorder quickly. True hyponatremia is associated with a low serum osmolality, meaning less than 280 milliequivalents per liter. Cases where serum osmolality is normal or high are termed pseudohyponatremia and will not be discussed. True hyponatremia is also always due to a relative excess of water, not a lack of sodium. Remember that the measurement of serum sodium is a concentration. It's a ratio of sodium in milliequivalents to volume of water in liters. If hyponatremia is present, the amount of water relative to the amount of sodium is increased. The relative excess of water in hyponatremia can occur with all three types of volume status: hypovolemia, euvolemia, and hypervolemia. I recommend you study these figures on the slide of the possible types of hyponatremia and to make sure the arrows and disorders make sense to you. Hyponatremia, again, is an imbalance of water ingestion and elimination. Usually it is in three categories. There's ingestion of too much water, which overwhelms the kidneys, and the kidneys can't eliminate that water fast enough. There's an ingestion of normal amounts of water, but the patient may have renal failure, then and again can't eliminate that water. Or there's ingestion of normal amounts of water in the presence of antidiuretic hormone. Here you can see the common causes of hyponatremia. We will focus on true hyponatremia: hypovolemic, euvolemic, and hypervolemic. You can see that renal insult failure is common amongst all three. For hypovolemic hyponatremia, there is a loss of sodium and water. Any type of water loss could cause hyponatremia. So things like gastrointestinal loss through vomiting or diarrhea, skin loss through burns or profuse sweating, they can cause hypovolemia and hyponatremia. For euvolemic hyponatremia, there's an increase in total body water, but a normal sodium. Common examples are water intoxication, syndrome of inappropriate antidiuretic hormone. In states of high antidiuretic hormone, hyponatremia will ensue and is one of the more common causes of hyponatremia. For hypervolemic hyponatremia, there's an increase of sodium in water. Examples may be the patient has congestive heart failure or chronic liver damage. Symptoms of hyponatremia are mostly neurological and depend on how quickly the sodium falls. In general, 125 or higher the patients are often asymptomatic. At lower than 125 but greater than 110, there may be some confusion, nausea, headache. But at lower than 110 serum sodium, the patient may present with seizures, coma. Again, rapid changes can cause brain edema and irreversible damage. For instance, a patient with acute hyponatremia after a marathon running may present with seizures. Now let's look at the opposite problem, hypernatremia. Hypernatremia is any serum sodium above 145. It's pretty hard to develop hypernatremia. If the hypernatremia is caused by a decrease in body water, physiologic mechanisms kick in that tell you to drink, and as long as you have access to water, you'll correct it yourself. If the hypernatremia is caused by excess intake of salt, the excess sodium will be excreted in the urine, provided that your kidney function is good. So most of the time, this disorder develops in someone who has an underlying neurologic or renal disorder. Although hypernatremia can be due to either a gain of sodium or a loss of water, it's most often due to the loss of water. Gain of sodium can happen by any cause listed. Loss of water comes from renal or extrarenal sources. Although fluid can be lost from all of these sources, not all fluid loss leads to hypernatremia. For hypernatremia to occur, the loss of fluid must have a lower concentration of sodium than of plasma. If fluid loss have a sodium concentration equal to or greater than plasma, hypernatremia will not occur. Infants and older adults are most susceptible to hypernatremia, sometimes because they don't have access to or can't physically or mentally obtain water to drink and correct the imbalance. Similar to hyponatremia, hypernatremia is classified as hypovolemic, euvolemic, and hypervolemic. For hypervolemic hypernatremia, there is a loss of water greater than sodium. Common causes are renal failure, gastrointestinal loss, or skin loss. For euvolemic hypernatremia, there is a pure water loss and a normal sodium level. This could happen with diabetes insipidus, or more commonly in patients who cannot access water, like we previously described. So these could be kids or elderly or hospitalized patients who can't ambulate. For hypervolemic hypernatremia, sodium gain outweighs water gain. This could be to iatrogenic causes, such as administration of hypertonic saline or possibly sodium bicarbonate use. This can also occur with mineralocorticoid excess via a tumor or exogenous steroid use. Again, the signs and symptoms of hypernatremia are generally CNS symptoms: confusion, irritability, lethargy, seizures, and coma. There may be signs of volume depletion in hypovolemia, such as tachycardia, dry mucous membranes. It's important to note that the severity and rate of sodium rise influences this symptom presentation. Treatment goals and monitoring for both types of sodium disorders are the same. You want to correct the sodium back towards the normal range and correct the volume imbalance. You also want to resolve any symptoms of the sodium and volume disorder and identify the underlying cause of the sodium and volume disorder and work to resolve or control that underlying cause so that the disorder doesn't reoccur. Monitoring can be thought of in terms of monitoring for the pharmacotherapy plan for efficacy and safety. We monitor efficacy, evidence that our plan is working, by periodically assessing the patient's symptoms of sodium and volume disorder. We also periodically measure the serum sodium to make sure that it's improving in the way we want it to be. For someone in healthcare setting, you can measure serum sodium every 2 to 4 hours in the first 24 hours, then less frequently after that. More importantly, whether you're treating hypo or hypernatremia, you cannot correct this serum sodium more than 8 to 10 milliequivalents per liter in the first 24 hours. Depending on the severity of the disorder, you may need to correct it more slowly than that. For example, a goal is 6 to 8 milliequivalents per liter in 24 hours, but never more than the 10 milliequivalents per liter. Therefore, measuring serum sodium is also a safety monitoring parameter, as well as the development of any adverse effects from the treatment used. Here's a helpful way to tackle sodium disorders. You first collect information about the patient's disorder by looking at their serum sodium concentration and symptoms. So you identify if the patient has hyponatremia or hypernatremia based on the serum sodium, and then assess the patient for symptoms, both general and neurological symptoms. Once you determine the sodium disorder, you have to determine the volume disorder is also present. This includes assessing the blood pressure and extracellular fluid volume. The differential diagnosis of sodium disorder can effectively be narrowed by determining the patient's volume status. This will help determine the underlying cause of the sodium and water disorder. All these steps are needed to be taken in order to create an effective plan for the patient. So, in summary, you want to identify the disorder and assessment of the serum sodium. So, determine if it's hyponatremic or hypernatremic. Assess for symptoms. Assess for the rate of development of the disorder. If the rate of development is less than 48 hours, it's classified as acute. If it's greater than 48 hours, it will be classified as chronic. Assess the effective circulating volume, the blood volume, by blood pressure and plasma volume assessment of the patient. Determine the patient's extracellular fluid volume status as hypovolemic, euvolemic, or hypervolemic, and then determine the underlying cause. In summary, sodium disorders are common, but may be complex. Always think about water balance, volume status, and correction rates of the patient. In class, we will review the treatment of these disorders. Thank you.